Hello. The topic of this video is key concepts in hypersensitivity. Now, I'd like to begin by stating that I am well aware that Dr. Gunn has provided outstanding material for you on hypersensitivity, and he goes into far more detail on the immunologic mechanisms than I will in this video. My goal in this video, however, is to provide some of the more essential facts, as well as to connect it with pathology that you have seen a little bit of already and which we will continue to see as we progress through the course. So with that in mind, I will compare and contrast the different types of hypersensitivity. Now, as you're aware, hypersensitivity is immunologically mediated tissue injury, and it can be caused by both exogenous environmental as well as endogenous self-antigens. And the real issue of hypersensitivity is that we have an imbalance between the effector mechanisms of immune response and the control mechanisms that limit response. And something that will come up again and again throughout the course is that susceptibility is associated with certain genes, both those related to HLA as well as non-HLA genes. So there are multiple causes of hypersensitivity. One is we can see autoimmunity to self-antigens as we get breakdown in self-tolerance. We can get reactions against microbes in which we have an excess response to microbial antigens, and an example of persistent microbial antigens is what we see in tuberculosis. We can get cross-reactivity, which we refer to also as molecular mimicry. We see this in rheumatic heart disease, which we will cover in week 12. And we can get an exuberant systemic inflammatory reaction, SIRS, and we see this in COVID-19. Another cause of hypersensitivity is reactions against environmental antigens that are typically harmless. So this can be dust or pollen. So as you are well aware, there are four types of hypersensitivity: immediate or type 1, antibody-mediated or type 2, immune complex-mediated type 3, and cell-mediated type 4. Now this is a table from your textbook, Robinson-Kumar, Basic Pathology. And I'm not going to go through this now. I'm going to work through this in the video, but this is a really excellent resource that you can use for review. So let's begin with our type 1 immediate hypersensitivity. And the central problem here is going to be an excess Th2 response with elaboration of IL-4, IL-5, and IL-13. And I'm going to show you a really nice figure that puts all this together. So we begin initially with the production of IgE antibody to some antigen, which we often refer to as an allergen because type 1 hypersensitivity is what we see in allergic responses. And with that, we get mast cell sensitization. So then when we get re-exposure with that same antigen, we have two phases. The first is an immediate response that occurs within minutes, 5 to 30 minutes, which is characterized by mast cell degranulation, which is going to cause a release of vasoactive amines and mediators, leading to vascular dilation, edema, smooth muscle contraction, mucus production, tissue injury, and inflammation. And then over the next 2 to 8 hours and evolving over days, we're going to get a late phase reaction which involves neutrophils, eosinophils, and in particular Th2 lymphocytes. This is going to cause the elaboration of additional cytokines that will lead to inflammation, tissue destruction, and mucosal epithelial cell damage. And some examples of diseases associated with type 1 hypersensitivity are anaphylaxis, allergies, and atopic forms of bronchial asthma. So let's look at this in a figure that I think will clarify matters for you. Here we have our mucosa, and we have our first exposure to this allergen. So for example, a little portion of pollen. This is going to be taken up by a dendritic cell. It's going to present it to a naive T cell, and this naive T cell is going to differentiate into a Th2 cell. There are some particular allergens or antigens that tend to drive Th2 production. This Th2 cell is going to stimulate a B cell that is also able to recognize this particular antigen, and it's going to stimulate this B cell with IL-4 and IL-13, which is going to drive it to form an IgE secreting plasma cell. At the same time, this Th2 cell is going to elaborate IL-5, which is going to stimulate eosinophils. Now let's switch over here. We next get the binding of our IgE antibodies to the receptors on mast cells, and now our mast cell is primed to recognize and degranulate when we get our repeat exposure to the allergen. So when this antigen binds, we get cross-linking, activation of the mast cell with release of mediators. And these mediators include our vasoactive amines and lipid mediators, leading to our immediate hypersensitivity reaction. And then over time, we also get the elaboration of cytokines that are going to cause our late phase reaction. And here's just a really nice figure from your textbook showing how this evolves over time, our allergen exposure, immediate reaction, and more slowly developing late phase reaction. And what we see in that immediate reaction is going to be mast cell degranulation. You can appreciate here these little dots of the granules from the mast cells. And the immediate response, we have edema, which you can make out here as this clearing due to fluid, and then this vascular congestion. Look how full this vessel is. And then over time, we're going to get the late phase reaction, which is going to cause the attraction of abundant eosinophils. Now this brings us to the next type of hypersensitivity, which is type 2 or antibody-mediated hypersensitivity. Now there are three ways that antibodies can cause damage. The first will be antibodies acting as opsons and stimulating phagocytosis. So as you know from immunology, phagocytes are going to recognize the Fc tails of our immunoglobulin as well as our complement breakdown products. And when phagocytes recognize these through their receptors, they will ingest these opsonized particles and destroy them. And examples of this include transfusion reactions, fetal immune hydrops, which we talked about last week, and drug reactions. Another type of pathology that we can see that is mediated by antibodies is inflammation. And this we associate when we see antibody deposition on fixed tissues. And I'll show you an example of that in a moment. What we have here is when antibodies are deposited on fixed tissues, they're going to activate complement following the classical pathway, which is going to recruit neutrophils and macrophages, leading to the release of reactive oxygen species and neutrophil enzymes. So there are some types of glomerulonephritis, as well as organ transplant reaction, which are associated with antibody-mediated hypersensitivity. And the classic example of this with this deposition on fixed tissues will be Goodpasture syndrome, and I'll show you an image of that in a moment. And finally, we have this very interesting mechanism in which we can get antibody-mediated cellular dysfunction without destruction. So two examples of this are Graves' disease, in which we get antibodies to the thyroid-stimulating hormone receptor. When these antibodies bind to the receptor, they stimulate the thyroid follicular cells to be generating thyroid hormone. This is when it's not considered appropriate for the homeostasis of the body. We can also see antibodies in the disease pernicious anemia, which we're going to discuss in week 19. This is when we get antibodies to intrinsic factor, and these antibodies don't destroy intrinsic factor or cause injury, but they do reduce the uptake of vitamin B12. Okay, so let's look at these three different mechanisms, beginning with our opsonization and phagocytosis. So here we can see a cell that's opsonized by antibody, which is recognized by a phagocyte and destroyed. Or we can have complement activation with this C3b particle, which is going to bind to the cell, again be recognized by the phagocyte, leading to phagocytosis. And the best example of this is one we discussed just last week, which is fetal immune hydrops. I'm not going to work through this entire figure because there's a video entirely on fetal hydrops, but as you recall, we have an Rh positive red cells in the fetus. The mother has developed antibodies to this Rh antigen. These IgG antibodies cross the placenta. They will opsonize these red cells, causing destruction, leading to hydrops, jaundice, and kernicterus. The next mechanism I'd like to discuss is the complement and Fc receptor mediated inflammation. And here we see a cell membrane which has a variety of antigens on it. We're going to get deposition of antibodies that recognize these antigens, which are going to stimulate neutrophils as well as activate complement. This is going to lead to the elaboration of neutrophil enzymes and reactive oxygen intermediates that are going to cause inflammation and tissue injury. Now, the example I mentioned is Goodpasture syndrome, in which we get antibodies to antigens in the glomerular basement membrane as well as in the alveoli of the lung. I want you to focus on this image on the left. This is immunofluorescence looking at this antibody deposition, and I want you to appreciate how smooth it is. This is because this antigen is expressed throughout this membrane. We're going to talk about this more when we talk about renal pathology as well as when we talk about lung pathology, but you can see how smooth this is. This is because the antibodies are deposited smoothly over this entire surface. By contrast, and we'll talk about this again when we talk about type 3 hypersensitivity, this is a glomerulus that has a granular appearance, and this is due to immune complex deposition. So we'll talk about that in a moment. And then the final pathway I want to discuss about antibody-mediated damage is when we get antibody-mediated cellular dysfunction. So this is the example I gave you of Graves' disease, where we have an antibody against the thyroid-stimulating hormone receptor on the thyroid epithelial cell. When this antibody binds, it's going to stimulate the cell to generate thyroid hormones without the appropriate need by the body. And this is an image that you will see when we get to autoimmune diseases of the thyroid. And you can see here, this is a thyroid gland that compared to what you saw in your anatomy with your FPC1, this is very juicy and revved up. And this is what the histology looks like, because each of these little follicular cells is being stimulated by antibody and trying to generate as much thyroid hormone as possible. Here you can see these clear vacuoles as they are eating up as much colloid as possible in order to generate that hormone. This brings us now to type 3 immune complex mediated hypersensitivity, and it begins with the formation of immune complexes. So we have some sort of protein antigen, and we develop antibodies over the period of about a week. These antibodies will then bind to serum antigen, resulting in antibody-antigen complexes. So these are floating around in the blood. The next step is going to be deposition of these immune complexes. Now, not all immune complexes are deposited, and it has to do with immune complex characteristics as well as local vascular alterations. So the immune complex characteristics, what it says in Robbins' basic pathology, is when you have excess amounts of these immune complexes. Essentially what happens is when you have antibody excess, it will bind to this antigen and it will precipitate. It's no longer soluble. However, if you have antigen excess, it will still continue to be in the blood and it will not be efficiently cleared by phagocytes in the spleen and liver. So where will these be deposited? Well, there's some very classic places, and you're going to see this again and again throughout FPC2. It has to do with local vascular conditions. So for example, in areas where we have high filtration pressure, such as in the glomerulus or the synovium, that's where we tend to get these immune complexes deposited, and that's why we will see diseases associated with this in these organs. Now, after we get this deposition, we're going to get immune complex mediated inflammation. So this takes place about 10 days later. And this occurs through activation of complement by the classical pathway because of the IgG and IgM binding. And the patient will present with fever, urticaria, joint pain, and lymphadenopathy. And some examples of immune complex mediated hypersensitivity are systemic lupus erythematosus and post-streptococcal glomerulonephritis. And let's look at a figure that goes over this. Here we have the first step, which is our immune complex formation. Here you can see the blood vessel. We have our antigen in circulation. Our B cell generates antibodies that are going to bind to this antigen, forming this antigen-antibody complex. And because, as you can see here, antigen is in excess, this will be soluble and will not be phagocytosed. It will next be deposited in areas where we have that high filtration pressure, like in the kidney. And we're going to get this deposition, and this is then going to cause activation of complement. And with that, we're going to get immune complex mediated inflammation and tissue injury as we bring in platelets and neutrophils. We get neutrophil lysosomal enzymes, etc. This can lead to vasculitis. And this is the classic example. This is lupus nephritis. Now recall when we looked at Goodpasture syndrome, how smooth that border was. Here you can see how granular it is, and that's because as these complexes are floating through the blood, it's going to be a random event where they actually impact and deposit. Now, our final type of hypersensitivity will be type 4 or T-cell mediated. And in this, this is driven predominantly by CD4 positive T cells. And what they do is they elaborate cytokines which lead to inflammation. Now, this is also referred to as delayed type hypersensitivity, or DTH. It tends to occur 24 to 48 hours after exposure to our antigen. And what happens here is we have Th1 cells activating macrophage, Th17 cells activating neutrophils, and our classic examples will be the tuberculin reaction. So when you get your PPD, we put in some protein and we wait 24 to 48 hours to see if you get a response. If you do get one, then we know that you've either been previously immunized or that you've been exposed to tuberculosis. This also plays a role in rheumatoid arthritis as well as drug reactions. Now, in the textbook, it mentions CD8 positive T cells, directly lysine cells, and they suggest that this can be a mechanism in type 1 diabetes. This is not entirely well demonstrated, but I'll show you an example in a moment. So let's look here again at a figure from your textbook. This is showing the more obvious pathway, which is CD4 positive T cell mediated inflammation, so cytokine mediated. We have our CD4 positive T cell, which is going to recognize this tissue antigen, differentiate along Th1 effector cells and Th17 effector cells. The Th1 effector cells are going to elaborate interferon gamma, which is going to classically activate macrophages that will cause inflammation and tissue damage. Our Th17 effector cells are going to elaborate IL-17, which is going to recruit and activate neutrophils, again causing inflammation and tissue damage. Now, this T cell mediated inflammation using interferon gamma, we can see over time, and we discussed this in week 2, the development of granulomas. If we have a persistent infection, such as what we see in tuberculosis, we can get continual elaboration of this interferon gamma, resulting in granulomas. And I'll show you an image of that in a moment. Now, the less commonly invoked arm is the CD8 positive T cell mediated cell killing. Again, our CD8 positive T cell recognizing antigen and is going to recognize cells that also have that antigen. And once it does that, it's going to kill those cells. So let's look first at a couple examples of CD4 positive T cell mediated inflammation. This is delayed type hypersensitivity in the skin. So this could be something, for example, like poison ivy. The person has had an initial exposure, probably didn't have any symptoms at all. On the second exposure, this is what we would see histologically. You can appreciate that there's an inflammatory infiltrate around these blood vessels. And at this point in your career, you're like, yes, but they could be anything. Well, we happen to know that they are CD4 positive T cells because we can do an immunohistochemical stain for that cluster, and we can see here that that is what they are. Here's just an example again from what we discussed in week 2, granulomatous inflammation. All of these epithelioid macrophages are gathered here because of interferon gamma that is released by CD4 positive T cells that are Th1, and this is in response to tuberculosis. Now, just to discuss at least briefly what we see with the CD8 positive mediated killing, this is a very rare and unusual site. This is type 1 diabetes. This is almost never seen. This is a biopsy which shows this islet of Langerhans that is infiltrated by CD8 positive T cells that are in the process of killing these islet cells, and this will eventually lead to full-blown diabetes. And I want to finish up with something which is a little bit more complicated, which invokes, again, our CD4 positive T cells, because it also brings in our immune complexes. And we'll talk about rheumatoid arthritis in particular when we get to the end of the course in week 20, when we compare and contrast rheumatoid and osteoarthritis. So you will see this figure again. Essentially, as we've discussed, with our hypersensitivity, we have susceptibility genes, failure of tolerance, we have our environmental factors, and again, we're going to differentiate along our Th17 and Th1 cells, and we're also going to have antibodies generated by our plasma cells. And as these enter the joint, they are going to stimulate synovial cells, fibroblasts, chondrocytes, and macrophages to release proteases and cytokines. We have a secondary component here where immune complexes are going to deposit on the synovium, and all of this together is going to cause joint damage. Again, we're going to cover this in week 20. This is just to provide a framework so you can see how important an understanding of hypersensitivity will be throughout this course of FPC2 and throughout your career. So thank you very much for your time and attention. I hope you have found this useful.